I'm Dr. Farzan Bahin, and it gives me great pleasure to present our article, Extended Endoscopic Mucosal Resection Does Not Reduce Recurrence Compared to Standard Endoscopic Mucosal Resection of Large Laterally Spreading Colorectal Lesions. On behalf of my co-authors, Drs. Maria Police, Stephen Williams, and lead author Professor Michael Burke from Westmead, Sydney, Australia, I'd like to extend our thanks to the ASGE and gastrointestinal endoscopy for sharing our work. Endoscopic mucosal resection for large laterally spreading lesions in the colon is now well established first-line treatment and has significant benefits compared to surgery. Clinically significant bleeding and post-resection recurrence remain limitations that we still need to address through our research work. Residual or recurrent adenoma occurs approximately 12 to 32% after EMR, depending on which series you look at, and in the majority of cases is unifocal, small, and can be easily treated at follow-up. However, there are obvious advantages to minimizing recurrence rates, including extending surveillance intervals, lowering the risk of adverse events, lowering costs, and increasing patients' acceptance for this procedure. It is thought, or our group thought, that a lot of microadenoma occurs at the edge of a resection defect that's not appreciated following the resection. And so we postulated that by increasing the margin of the defect, by extending the resection, we would limit recurrence rates. And this was the motivation to perform this study, to essentially simply extend the resection defect rather than doing any additional modality in evaluating that effect on recurrence rates. The method of our study was to evaluate the large multi-center prospective observational ACE study, the Australian Colonic Endoscopic Resection Study, and we looked at data from the lead site at Westmead Hospital. We essentially started off in 2008 with what's called standard endoscopic resection technique, which involved including a 1 to 2 millimeter tissue margin of the resection defect. And we moved on to a more extended margin that included at least a 5 to 10 millimeter rim of normal tissue during the resection. And we compared the extended resection group to the historical standard group and evaluated the key outcomes. Our primary endpoint was recurrence rate, which was defined as histologically proven adenoma at surveillance 4 to 6 months following the resection. Other endpoints included safety of the extended EMR procedure. The findings of the study and other relevant points are obviously covered in the paper, but to summarize, the primary endpoint of residual or recurrent adenoma rate was not statistically different between the two groups. It was 10.1% in the extended EMR arm and 11.7% in the standard EMR arm. Of note, extended EMR was associated with intraprocedural bleeding with an odds ratio of 3, with the other factors related to intraprocedural bleeding being lesion size and a Paris 1S component. Other factors related to recurrence, noting that extended EMR did not significantly affect recurrence, were intraprocedural bleeding, lesion size, as well as the use of an adjuvant thermal therapy to remove visible adenoma that could not be removed by snare technique. So this has to be kept in, the findings have to be borne in light of there being slightly different characteristics between the two groups that weren't entirely matched, and that this was obviously a study comparing two cohorts, one present cohort and a historical cohort. In terms of the discussion for this study, we were quite surprised by the findings, as we postulated that by extending the EMR defect, we would actually remove inconspicuous adenoma at the lesion margin. However, the negative finding may potentially be explained by microadenoma that's sitting on the vertical step between the defect and normal tissue, not really being entirely captured by a snare-based technique. And a similar principle may apply in tissue bridges between resections within the defect. It is interesting to note that the majority of adenoma was found on the edge of the scar in both groups, indicating that despite extending the defect, enough microadenoma is obviously not being captured. This certainly leads to the question of whether alternative methods are applicable. Interim results of a randomized study led from our group do suggest that the use of adjuvant thermal ablation of inconspicuous defect edges significantly reduces recurrence rates. I think the exact pathophysiology of recurrent or residual adenoma is yet to be elucidated, and certainly the question for ongoing research remains. Performing a randomized trial and a study of our methodology would have been the ideal scenario to answer whether the negative study was a false negative finding. But such a study is obviously logistically challenging to perform. Of note, extended endoscopic mucosal resection led to an increased rate of intraprocedural bleeding, and so that has to be taken into account if wanting to perform this procedure. In summary, the use of extended endoscopic mucosal resection did not significantly reduce recurrent or residual adenoma rates, and in fact caused increased rates of intraprocedural bleeding, which in turn were related to recurrent and residual adenoma rates independently. We certainly would not necessarily advocate the use of extended EMR as a standard treatment for this sort of approach, and believe that perhaps other modalities such as adjuvant thermal ablation may be more favorable as a way to prevent recurrence after EMR. I'd like to thank the audience again for their participation and reading our work.